Welcome to today's KangaTech webinar. My name is James Evans and I'm the Vice President for Customer Success here at KangaTech. Today we have a presentation from Daryl Carter of Leeds United. In Daryl's role at Leeds United as a senior physiotherapist, he's been utilising the KT360 for a number of years now and could have presented on a number of different topics. But for today, the presentation will look at a specific case study. Unfortunately, Daryl is unable to join us today, so we have a pre-recorded presentation for you. As a result, there won't be a Q&A session at the end. We do ask you, if you have any questions, that you send them over to us on our social media channels or through the email address listed at the end of the presentation, and we'll do our best to get them answered for you. Without any further ado, let's get into the presentation.
Hi guys, I'm going to present today a clinical case study that we've had here at Leeds United, which is looking at how the KangaTech and the data we collected helped to shape the clinical decisions made through the process with this player. But before we start that, just a little bit of an introduction about myself. So I've got my background was in sports injury rehabilitation, and then I completed my MSc in physiotherapy at York St John. And then for the last 10 years I've been working in professional football, moving from the academy up into the first team stage where I am now. More recently, my role has developed more towards the testing of the players, looking at both the monitoring of the fit players and looking at the outcomes that we use and test with the injured players during rehabilitation, and then using this with our rehab coach to help guide where we go through the process and when we think the players are ready to move on through the different stages. So the clinical case we had was a player that sustained a right-sided pyramidalis anterior pubic ligament adductor longus complex, which for the rest of the presentation is just going to be called the plaque injury. This was an acute onset when he was stretching for a pass out to the side. It wasn't a full overstretch, but it was more the speed of the movement and the quick reaction to the pass where he felt the initial onset of the pain. Initially, he trained and completed 2 games in 7 days after this incident, which we were sort of managing him through. And then after the second game, it became worse, and it was at this stage that he decided he was unable to continue. So an MRI scan was obtained, which confirmed this diagnosis. So before we look at the case, let's have a look at the sort of anatomy of the plaque itself. So it's first described in this paper by Shoulders, which is the great paper outlining in great detail, and it's got some great pictures in there of the anatomy. But initially, if you look at this image here, which is the sagittal view, you can see that you have the rectus abdominis coming down with the pyramidalis muscle just in front, and then you have the anterior pubic ligament here attaching onto the pubic symphysis, and then the adductor longus tendon coming up from beneath. And then in between you have the fibrocartilage disc, which attaches that adductor longus tendon again into the pubic symphysis. So the main findings from this study were that it identified the pyramidalis as the only muscle anterior to the pubic bone, and that the rectus abdominis itself, it wasn't connected to the adductor longus, and this connection is more made via the adductor longus, the anterior pubic ligament, and the pyramidalis, and they attach via the anterior pubic ligament, and that the adductor longus tendon origin is stabilized by the anterior pubic ligament and the fibrocartilage attachment into the pubic bone itself. So when you look now at the injuries to this area, you have the classification system, again described by Shoulders in this paper. So ultimately there's 6 different types of the plaque injury, which I'm not going to describe here, but you can quickly see them here in this table. But typically they're classified based on the fibrocartilage avulsion, or whether the pyramidalis is separated or connected from the adductor longus, and if there is an intact or partial peteneus tear as well. So they're the main three things that they're looking at to determine the type of injury. So if you look at the images, you can see again the similar one to what we've just seen on the sagittal side, where you can see the pubic ligament with the red dotted lines here, which is sometimes where that will come away from the pubic symphysis, and you might get the tear here within the fibrocartilage disc, and you may also get a tear here between the adductor longus and the anterior pubic ligament, which would then lead to that separation between the pyramidalis and the adductor longus. And then looking here at the front, you can see anterior pubic ligament coming across, pyramidalis coming down, and then here you have the adductor longus and the peteneus, and this is where you sometimes get the tear here, and then when it talks about the peteneus involvement, it kind of strips across here, and it might be the peteneus is tearing away alongside the adductor longus here. If you look at the paper described, there's great images for each of the 6 different classifications and some of the MRI views, so it's well worth looking at that paper. So back to the clinical case that we had. So ours was a type 6, so just a partial fibrocartilage avulsion, but the pyramidalis and the adductor longus were both intact, and there was no involvement of the peteneus itself. So the clinical findings we had was pain on the passive range of movement for abduction, for flexion, and internal rotation. Typically the pain came on towards the end of the ranges. He had pain and he was weak on adductor contraction in all ranges, but this was more at the long lever, so when he was tested at sort of at 0 degrees. He had pain on the pubic stress tests at the end of the bed, and pain on palpation around his adductor longus tendon insertion and the pubic bone. So initially at this point, our differentials were, is this an adductor longus origin pathology, or is this actually pubic bone related pathology? So we had the MRI scan. This first image here is the normal anatomy. So you can see here, this black sort of region here is the fibrocartilage disc, which attaches into the pubic symphysis. And then here you can see for our player, if the fibrocartilage disc is here, and you can just see this sort of slight sliver through the middle here with the partial thickness tear, making this the type 6. And there was a little bit of edema within the pyramidalis muscle itself, but there was no tear. So the management options were discussed with the surgeon, and the 2 routes, conservative option or surgical option. The conservative option was looking at 3 PRP injections into the fibrocartilage at weekly intervals, with a graduated progression through rehabilitation, looking at timeframes of sort of 6 to 8 weeks. The surgical option we were looking at was a plaque repair, with a 10 to 12 week surgical protocol for rehabilitation. The decision was made to go conservative based on a discussion with the consultant, and the consultant felt that 80 to 90% of these would heal conservatively, and initially the view was within the first sort of 3 to 4 weeks we should have an idea if the conservative option was going to be successful. So that's the route we decided to go down. So looking at the conservative progression, the key markers we were using was looking at the hip range of movement, so any improvements made in flexion, internal rotation, abduction. Looking at any improvements in adduction strength in the outer ranges, and this was just manually initially on the bed. Then we were looking at the adductor testing on the KangaTech, which we started in a more hip flexion position, so at 60 degrees, and then moved through down to 0. And then once these improved, we started to look at unilateral tests moving out into abduction, and then looking at the progression with gym loading into the deeper ranges of hip flexion in the gym, both in the sagittal and the frontal planes. So in the first 4 weeks, he had the 3 PRP injections at weekly intervals, and we found that reduced the range of movement for flexion, internal rotation, and abduction with this sharp pain at the end, and this was the same day in, day out, there wasn't much of a change in this pain. There's a small reduction in pain on the 0 degree squeeze from 6 to 10, and there were small improvements in his squeeze strength, but then this plateaued. And the outer range strength remained reduced with a minimal improvement, and the pain in this remained sort of at 4 out of 10. Here you can see the squeeze scores that we had in this initial stage. So there was the initial improvement, and then here is where we were going through the 3 PRP injections. And we had we virtually had a flare up after each of the injections. So he'd have injection, be sore for a few days, the strength would drop down, it would improve, and then again the same pattern would follow after each injection. He was squeezing around 30 kilograms at this point, which for him is roughly sort of 50%. The gym progression was sort of sagittal plane loading patterns that I'm not going to go into in this presentation in terms of the full process, but I'll just give you sort of a brief overview as we go through. So in this position, we're just looking through sort of bilateral squats, split squats, step ups, and working through the depth. So improving the range, going into deeper hip flexion, and increasing the height of the box for step ups as we were able to load him into that deeper hip flexion, as that was one of the areas that he was sore on and we could use as the marker. And then looking at progressing sort of the concentric and the eccentric nature of the exercises. So looking after this at sort of weeks 4 to 10, due to, as we've seen, that lack of progression initially, we were considering whether the surgical option was going to be the better option to go with. He had repeat ultrasound scans at each injection, and this showed a progression in the fibrogranulation tissue at the site of the fibrocartilage tear. And we had the repeat MRI, which also showed some healing, but that it wasn't complete. So on the image here, you can see the one on the left was at 6 weeks, and the one on the right was initial. And you can sort of see within the fibrocartilage, there's still that little tear in there, showing that it wasn't a complete healing, but the radiologist felt that there was a healing response going on, which was supported by the ultrasound scans. So the decision was made, again, along with the time frame of the season here, that if we'd gone straight for surgery, then potentially we would have ruled the player out for the rest of the season anyway. So given the small progressions that was made and a little bit of a healing response seen on the imaging, it was decided that we would continue with the conservative approach. And then literally after the next sort of 10 days at this point, we saw a big improvement in terms of his clinical situation. You can see this was the squeeze strength from previous, and then all of a sudden there was a big improvement in his squeeze scores, which was obviously very positive, as it hadn't shown as much progress in the whole 4 weeks prior. And then this improvement continued as we were getting towards sort of the 10-week mark. The pain dropped down to a 1 out of 10 on the outer range testing, and the strength improved. The gym work was progressing from sagittal plane to now working in the frontal plane and adding the load. We could, again, in that frontal plane, we started off getting deeper into hip flexion and sort of working laterally onto a higher step. We progressed this function outside, so we started straight line running and started some change of direction work. And then you can see from here, again, as we started to progress his function, that his strength scores continued to improve. A little bit of the fluctuations, they go up and down, but generally on the whole, his strength scores were improving, along with sort of his clinical picture on the bed. So at this point, we're now getting towards 10 to 12 weeks, and he's progressed with his speed work outside, both in a straight line and looking at his change direction. However, as we're now getting into this point, we started to get a little bit of awareness now around the proximal adductor origin. We started to bring a little bit of ball striking into the sessions, and again, we started to get some awareness more after the session. and his strength scores started to decrease at this point. We noticed here that he was now starting to lose his strength as we progressed small steps outside. He just couldn't maintain. He had small awareness during the sessions, but it was more that carryover into the sessions the next day and the testing. And importantly, he also had small awareness reaching for a pass, which was the initial mechanism that caused the injury. So we had a review with the surgeon at 12 weeks and decided on surgery. This was based on the fact that he was unable to maintain strength, and the pain started to increase on stretch and on contraction. And he had a repeat MRI scan again at this point, and this showed that the plaque is still present, but that there was edema within the pyelodermis still, which suggested that maybe that tear through the fibrocartilage disc was unstable, so the muscles around here are having to work harder to stabilize the area. So at this point, the time frames have been much longer than initially thought from the onset, but progression was being made. So we felt that conservative was giving the player the best chance to return, and then given the specific point in the season that we were at, if we'd gone down the surgical route earlier, we would have been ruled out for the season anyway. So we felt, given the time of the season, the progressions that were made clinically and in the strength, that it was worth staying with the conservative approach. So we decided on the surgery, and it was decided that we would go for a plaque repair due to the low energy mechanism and the potential for further progression of the plaque type 6. So we didn't want that tear to get bigger or re-injure. So it was fixed with 4 anchors to the anterior ligament to the pubis, restoring good anatomical alignment. And then there was a partial release at the adductor longus MTJ a little bit more distally, with a dynamic ultrasound review showing good tension on the adductor longus on both static and dynamic assessments, and that there was normal morphology at the site of the adductor longus release. So the post-op rehabilitation summary is a 10 to 14 week protocol where we used the same objective markers as we used pre-surgery, and we had the same sort of pattern of symptom resolution during this process. So the sagittal movements were clear before frontal, and looking at loading out of the deeper ranges of hip flexion and progressing into these, and then adding the load into these positions. And this was the process. So you can see fairly acute management in the first couple of weeks, and then we progress into more of the gym stage rehab. And then at 6 weeks, we could start to become a little bit more functional, start with the straight line running. And then as you get towards the later stages, you can start bringing in short kicking, progressing through the ranges of kicking. And ultimately, there was a return to training or return to play between the 10 to 12, 10 to 14 week period. And the principles that we were looking at was, again, looking through that sagittal plane and the frontal plane movements, and also now looking at the adductor load. So initially we started off with synergistically through knee flexion and hip extension, so that we could load the adductors early but without squeezing or going through adduction. And then we could start off loading via adduction but in more hip flexion, and then coming into more neutral, and then taking it into more abduction. So the strength progressions that you can see here, so this was his adductor squeezes. So you can see initially, like we had the injection period, then we had that initial improvement through the conservative approach, and then the drop off in function. And now here, this is the post-surgical progression. So you can see the continued improvement in his adductor squeeze scores as the strength improved and as the function improved. and that these scores were maintained when we started to move at higher speeds and striking the ball harder and over long distances, which was obviously different to when we got to that same stage in the conservative approach. And this was looking at his sort of unilateral in 30 degrees of abduction. So you can see the conservative approach here. And then as we then started the post-surgical approach, you could see his strength improved. It was actually higher than where he'd got to conservatively. And for this, the ratios started to come back down into the area that we would like it. At this point, this testing here isn't his return. This was when we then ceased testing at this position and moved into more abduction and started to look at the single leg in 45 degrees, which you can see here. So again, we have the post-surgical stage, sorry, the pre-surgical stage, conservative, and then you can see here we had the post-op stage where he started to improve. Although he had one minor episode here where he was a little bit sore one day and it dropped, but you can see that quickly recovered and he came back up to where we would expect it to be. And again, this was higher than the conservative bit, and the pain was much less, virtually minimal by the end of the stage. And again, you can see that he's towards the end of it, he just got back down into the ratio and the symmetry that we would like to see with that balance, apart from this part here, which was when he had that little bit of soreness, that little bit of awareness. So that was looking at his loading just via this injury, but we actually, adductor monitoring is one of the things we do to monitor all of the players, and I think it's interesting to look at this player as a whole and look at the bigger picture. So this last little snippet here is where we've been looking at sort of with this current injury, and now this is all looking at the match day +3 testing that we have for this player in total. And you can see here, this is his usual sort of monitoring when he's fit and when he's playing the games, with sort of a fluctuation in load. Interestingly, for this player, he had a big drop off at this point. So this was at the end, towards the end of one season, where he actually had a little bit of discomfort around his adductor and overload around his pelvis, and then came back in pre-season testing, and then actually once we'd started, he was unable to maintain. He was still quite sore, quite overloaded in here. However, he was still able to train and play, so the decision was made through this period was to try and maintain this player, to keep him fit, keep him going out, and he was happy to continue to train and play until he got to the point where it was decided actually he had a posterior wall repair, and then you can see the strength post that had just started to improve. But it was just unfortunate that he then ended up with the plaque injury as he was coming back. So there's been quite a long period of managing for this player. And when you look at the overall approach that we've done from our screening, so we looked at the hip screen, it was that these were some of the areas that we identified that we needed to work on. So we were looking at his hip extension, and his hip flexion scores weren't really where we would expect them to be. Looking at his lower abdominals and his obliques, and looking at that control there in his lumbar-pelvic control, again we identified these as areas that he needed to work on. So throughout this whole phase, these have been trend sort of themes that we've been looking to work on with this player all the way through. And then lastly was looking at the way that he produced vertical force. So initially, just as pure vertical force production was quite low for his size, and then looking at how, specifically looking at his sort of gastrocs, looking at his soleus, looking at his quads, and the ratio between those was a little bit off as well. So again, this has been an area that we've tried to focus on during the rehab process to give that overall approach for this player. So then that takes us to the pitch progression towards the end of his rehab. So we were at 10 weeks post-op. He completed the pitch sessions. He progressed through straight out running. He's changed direction, acceleration, deceleration, and he was able to complete full sprinting. And these were all pain-free. We completed the yo-yo test, and he was back to his previous levels that he had earlier on in the season. His ball striking progressions were cleared, so we started off obviously at the shorter range, less than 10, all the way up to his long range passing and varying the angle of the passing, the different sort of leg swings that you would do through sort of instep contact, laces contact. And this was right at the end of the season. So we were happy at this 10-week phase that everything had been ticked off in terms of what he needed to be able to do in order to return to training, if there was training. So we've looked at now his reintegration is going to be in pre-season. So we're happy now that he's able to follow the same off-season program that the rest of the team are completing, with his individualized sort of gym program to do, still working on those same themes that we had previously identified. So on reflection, looking back at the case, obviously the return to play took much longer than initially was thought, but with hindsight I think it would be easy to sit here and say, if we'd gone for surgery straight away, then it would have been much quicker, and it would have been a much smoother process, and the player would have been back quicker. But I don't think we would change the decisions that we made, given the improvements that we'd seen through the conservative rehab, especially with the timings of the season that we were at. I think every effort was made to give the conservative approach the time it needed, with a view that if his own anatomy was probably the best to start off with, then I think as soon as it became apparent that maybe wasn't going to work, it was a swift decision then to go for the surgical option. So I don't think I would change. I don't think as a department we would change the approach that we made. Looking at some of the testing protocols that we used, this was the first time that I'd used the unilateral adductor protocol, and I found that to be a great protocol for this, and I found it highlighted differences between left to right better than the squeeze tests. And I think moving forward, this is one that I'll definitely look to use with our players in the future. So you can see the test position here on the right, and then just stabilizing the pelvis to now enable the player to produce a force. And then looking at the hip screen and looking at the hip extension was a very interesting one. So typically we'd use the position with the hips in less flexion over the foam roller, and then extending. And this is what we used to find that we felt his hip extension wasn't quite where it should be. However, having a play around with some of the different positions, I've come to this position here on the left, where it's in approximately sort of 45 degrees of flexion, supported on the box, and I found that he was able to produce much more force into hip extension in this position, which I then looked at 4 or 5 different players and completed the 2 tests, one after the other, in the foam roller position and the box position, and found that all the players could produce much more force in this position, which has led me to think about the screening that we use when you're making decisions around which areas maybe players need to work on, is ensuring that actually is the testing protocol identifying the weakness that we think it's identifying. Are we testing in the right position? So are we actually getting the outcome that we need? And I think for me, moving forwards, this hip extension protocol here is probably one that I'm going to continue to use with with our players. So hopefully I've shown how we have used the testing and the monitoring of the player to help and guide the clinical decision making. Thank you for listening.
I'd like to thank Daryl very much for putting that presentation together and taking the time and effort to prepare that for us. I hope everyone that has tuned in live or chosen to watch this on catch up found value in that. As I mentioned, we'll be able to get those questions that you may have answered from Daryl. If you could drop us a message over social media channels or use the email address listed there, and we'll be able to get those questions answered for you. Thank you for joining us live and for watching us on catch up, and we'll see you again in a future KangaTech webinar. Thanks.